Put your hand on your upper abdomen, just below your rib cage, slightly to the left of center. That is where your pancreas sits. You have almost certainly never thought about it. You have never felt it. It has never hurt. And that is exactly the problem. Most people live their entire lives without once considering this organ, until the day they cannot ignore it anymore. By that point, in the majority of cases, the damage is already significant. The pancreas can lose 80 to 90% of its function before producing a single symptom most people would connect to it. By the time the pain starts, by the time the diagnosis is made, the damage is often irreversible. Most people know the pancreas makes insulin. That is one function. It has a second function that is equally critical and almost never discussed outside of a gastroenterology textbook. Every gram of food you eat, every piece of protein, every fat molecule, every carbohydrate requires pancreatic enzymes to be broken down and absorbed. Without those enzymes, food passes through you unchanged. The pancreas produces digestive enzymes that break down every gram of fat, carbohydrate, and protein you eat. When enzyme production fails, you can eat a perfect diet and still be malnourished. The nutrients pass through you unabsorbed. I'm Dr. Arthur Sterling. Subscribe right now and hit like. What comes next, nobody will cover at your next appointment. To understand the 7 warning signs, you need to understand what the pancreas actually does and why it fails silently. The pancreas is a soft, elongated gland approximately 6 inches long, sitting behind the stomach, tucked against the spine. It is not visible from the outside. You cannot feel it through the abdominal wall. It produces no obvious signals when it is under stress. It simply works until it cannot. The pancreas has 2 completely separate functional systems operating simultaneously inside the same organ. The first is the exocrine system, roughly 95% of the pancreas by volume, which produces digestive enzymes including lipase for fat, amylase for carbohydrates, and protease for protein. These enzymes travel through the pancreatic duct into the small intestine, where they perform the work of breaking food into absorbable components. The second is the endocrine system, tiny clusters of cells called the islets of Langerhans scattered throughout the gland, which produce insulin and glucagon, the hormones that regulate blood sugar. These 2 systems share the same organ, the same blood supply, and the same vulnerability to damage. When the pancreas is damaged, both systems fail simultaneously. Blood sugar rises as insulin production drops. Digestion fails as enzyme production drops. 2 catastrophic processes in the same organ at the same time. The reason pancreatic disease is so consistently missed comes down to anatomy. The pancreas sits retroperitoneally, behind the abdominal cavity, in front of the spine, surrounded on all sides by other structures. It has no direct nerve supply that produces early warning pain. It has no capsule that stretches under pressure the way the liver capsule does. When it swells, when it inflames, when it degenerates, it does so in a space that absorbs the damage without transmitting it to the surface where you could feel it. It has no capsule that stretches and produces pain when it swells. The pancreas hides behind everything else and fails quietly until it cannot fail quietly anymore. By the time the pancreas produces pain that a patient describes as significant, pain they would actually mention to a doctor, the inflammatory or degenerative process has typically been underway for months or years. This is why the warning signs I'm about to describe matter so much. They appear before the pain. They appear before the diagnosis. They appear when something can still be done. Here are the 7 signs. None of them says pancreas on the label. That is exactly why they are missed. Go through this list honestly, because each one of these is something most people have explained away at least once already. Sign 1. Floating, greasy, foul-smelling stools that are difficult to flush. This is the sign I want you to pay the most attention to, because it is the most specific early indicator of pancreatic exocrine failure, and the one most consistently dismissed as a dietary issue. When the pancreas cannot produce sufficient lipase, the enzyme that breaks down dietary fat, fat passes through the intestine completely undigested. It is not absorbed. It simply travels through and exits unchanged. The result is fatty stools that float, are pale or clay-coloured, leave an oily film in the toilet bowl, and are profoundly foul-smelling. If this describes your stools consistently, not occasionally, but regularly, this is a pancreatic signal until proven otherwise. Most patients I see with this symptom have had it for months before mentioning it to a doctor, because they are embarrassed or because they assumed it was something they ate. It is not something you ate. The distinction matters. Steatorrhea is consistent, happens after most meals, does not resolve with dietary changes, and is accompanied by a specific odour that patients invariably describe as unlike anything else they have experienced. If you have been avoiding public restrooms because of this symptom, that avoidance is a clinical data point. Write it down and bring it to your appointment. Sign 2. Upper abdominal pain that radiates to the back. Pancreatic pain is one of the most distinctive patterns in all of medicine, and one of the most consistently misattributed. Patients arrive having been told they have gastritis, acid reflux, a pulled muscle, or a herniated disc. They have tried antacids, physiotherapy, and rest. Nothing has worked, because the source of the pain is not where anyone has been looking. It originates just below the rib cage and radiates directly through to the mid-back. It worsens after eating and characteristically improves when the patient leans forward. This postural relief pattern is one of the most specific clinical indicators of pancreatic origin. The leaning forward phenomenon occurs because it reduces the pressure of surrounding structures on inflamed pancreatic tissue. Patients discover this accidentally. They find themselves hunching forward at the dinner table without knowing why. That positional preference, combined with upper abdominal pain after meals, is a clinical flag I act on immediately. Sign 3. Unexplained weight loss without dieting. This is one of the most alarming signs on this list, and paradoxically, one of the most frequently minimized by patients who are initially pleased by the weight loss and do not report it unless asked directly. When pancreatic enzyme production fails, the body cannot absorb calories from food regardless of how much is consumed. Protein, fat, carbohydrate, all of it passes through largely unabsorbed. Patients eat normal quantities and lose weight steadily. This is not appetite loss, it is malabsorption. Weight loss of more than 10 pounds over 2 to 3 months without dietary change requires immediate investigation. The critical distinction is between intentional and unintentional weight loss. Patients with pancreatic malabsorption often report increased hunger alongside the weight loss. Their body is not receiving the nutrition it needs despite adequate food intake. They eat more. They lose weight anyway. That combination, increased appetite plus unexplained weight loss, is one of the clearest signals that something is wrong with absorption, not intake. Sign 4. New onset diabetes in someone with no family history and no obesity. This sign is the one that delays diagnosis most consistently. When a doctor sees a new diabetic, the automatic assumption is type 2. The treatment protocol begins, and the question of why this person developed diabetes at 58 with no risk factors is never adequately investigated. New onset diabetes in this profile is frequently secondary to pancreatic damage, called pancreatogenic diabetes type 3C. It is misdiagnosed as type 2 for years, while the underlying pancreatic pathology goes uninvestigated. Type 3C diabetes behaves differently from type 2. It is more brittle, harder to control, and is accompanied by signs of exocrine failure. When new diabetes appears alongside unexplained weight loss, bloating, and prior abdominal pain, the pancreas is the diagnosis until proven otherwise. Sign 5. Persistent bloating that begins within an hour of eating. Almost everyone experiences occasional bloating. What I am describing is different, a consistent, predictable distension that occurs after virtually every meal, regardless of what was eaten. Patients describe feeling pregnant after a sandwich. They have tried eliminating gluten, dairy, beans, and cruciferous vegetables. Nothing changes, because the cause is not the food. Undigested food reaches the large intestine intact, where bacteria ferment it, producing gas in quantities the intestine cannot manage. The bloating begins within 30 to 60 minutes of eating and persists for hours despite normal meal sizes. This is why elimination diets fail. You can eliminate every common trigger and the bloating continues, because the trigger is not what you are eating. It is what your pancreas is failing to do with it. Sign 6. Yellowing of the skin and whites of the eyes. Of all the signs on this list, this one demands the most urgent response. It should not be monitored. It should not be Googled. It should prompt a call to your doctor or an emergency room visit within hours. Yellow skin, dark brown urine the color of strong tea, and pale clay-colored stools together mean bile is backing up into the bloodstream. This combination is a medical emergency requiring same-day evaluation. The mechanism involves the common bile duct running directly alongside the head of the pancreas. When a mass or severe inflammation compresses this duct, bile cannot reach the intestine. It backs up, bilirubin accumulates, the skin yellows, the urine darkens, and the stools turn pale. Painless jaundice in an adult over 50 is pancreatic cancer until proven otherwise. Not the most likely explanation. The first explanation to rule out. Sign 7. Mid-back pain with no mechanical cause. This is the sign that sends people to physiotherapists for months. It generates MRI scans of the lumbar spine that come back unremarkable. It gets labeled as muscular strain or postural dysfunction, while the actual cause continues to progress untreated. A deep, persistent mid-back pain that does not change with posture, does not respond to anti-inflammatories, and is present at rest and at night is a pancreatic signal, not a spinal one. Mechanical back pain changes with position. Pancreatic mid-back pain does not. You can stand, sit, lie down, stretch, walk. The pain remains exactly the same. It is present at 3 in the morning when you have been lying still for hours. That indifference to posture, that mechanical unresponsiveness, is the clinical signal that this pain is coming from inside the abdomen, not from the spine behind it. Let me tell you about a patient I will call Carol, 57 years old, retired nurse, which makes what happened to her even more instructive. She came to see me after 14 months of symptoms that had been investigated and explained away at every turn. It had started with bloating after meals and stools that were loose, pale, and floated persistently. She had been told it was irritable bowel syndrome and given a low FODMAP diet. Nothing changed. 6 months in, she had lost 16 pounds without trying. She had been told this was perimenopause-related metabolic change. She had developed persistent mid-back pain. She had been referred to a physiotherapist for 6 weeks. The physiotherapy made no difference whatsoever. Then her fasting blood sugar came back at 118, pre-diabetic range. She had no family history of diabetes. She was not overweight. She had been placed on metformin and told to reduce refined carbohydrates. Nobody had asked why a 57-year-old woman with no risk factors had suddenly become pre-diabetic. When Carol sat across from me, I noticed 3 things before she said a word. She looked thinner than her chart suggested. Her skin had a very subtle yellowish tinge she had attributed to the lighting in her house. And when I asked her to point to where her back hurt, she placed her hand flat across her mid-back, exactly where the pancreatic body sits. I ordered a CT scan of the abdomen with contrast that same afternoon. I did not wait for a referral. I did not schedule it for the following week. I called the radiology department directly and explained the clinical picture. The report came back within 24 hours. A 2.4 centimetre mass in the body of the pancreas, stage 2, operable. Her surgeon told her afterward, another 3 to 4 months, and this would have been a very different conversation. 14 months of symptoms, 4 separate explanations. IBS, perimenopause, back pain, pre-diabetes, each one individually plausible. All of them wrong. The pancreas had been sending signals for over a year. Nobody had read them together in the same room until that appointment. Carol is alive today. The margin was measured in months. Now let me tell you what actually damages the pancreas, because most people point to one cause and miss the others entirely. Chronic alcohol consumption is the most well-known, but the threshold is lower than most people assume. We are not talking about end-stage alcoholism. We are talking about consistent, moderate drinking over years, 2 to 3 drinks per day, every day, for a decade. Regular consumption of more than 2 to 3 drinks per day over years produces chronic, low-grade pancreatic inflammation that most people never feel as acute pain. It progresses silently, scarring the gland and reducing enzyme and insulin production incrementally. The damage is not from individual episodes of heavy drinking. It is from the accumulated inflammatory burden of consistent, moderate intake over time. The pancreas does not announce this process. It simply becomes progressively less capable until the deficit becomes clinically visible. Gallstones are the second major cause, and one that is entirely correctable if caught early. When a gallstone passes into the common bile duct and temporarily blocks the pancreatic duct, it triggers acute pancreatitis. Repeated episodes produce chronic damage that is cumulative and irreversible. Approximately 35 to 40% of all acute pancreatitis cases are caused by gallstones. An abdominal ultrasound detects gallstones with over 95% accuracy. If you have ever had episodes of upper right abdominal pain after fatty meals, an ultrasound is not optional. Many people have had these episodes and attributed them to indigestion, a heavy meal, or a stomach bug. They resolved on their own. The gallstone passed. But each episode left a small amount of inflammatory damage in the pancreatic tissue, damage that accumulates silently with every subsequent episode. And the cause that is being recognized with increasing urgency in current research, non-alcoholic fatty pancreas disease. Fat accumulating inside the pancreatic tissue is present in an estimated 16 to 35% of the general population, rising to over 50% in people with obesity or metabolic syndrome. It produces progressive inflammation, impairs both exocrine and endocrine function, and is directly associated with increased pancreatic cancer risk. It is almost never screened for. Pancreatic cancer has the worst 5-year survival rate of any major cancer, approximately 12%. The reason is not that it is inherently untreatable. It is not that oncology lacks effective protocols. The reason is that it is almost never caught at a stage when those protocols can produce lasting results. By the time most patients are diagnosed, the disease has already spread beyond the pancreas. The window for surgery, the only treatment that offers meaningful long-term survival, has closed. Stage 1 pancreatic cancer has a 5-year survival rate of 20 to 30%. Stage 4, how the majority of cases are diagnosed, has a survival rate of approximately 3%. The difference between those two numbers is detection timing, nothing else. The healthcare system has no routine screening protocol for pancreatic disease in the general population. There is no pancreatic equivalent of a mammogram, a colonoscopy, or a PSA test. There is no blood marker on a standard annual panel that reliably detects early pancreatic damage. The system is structurally set up to find this disease late. Not by design, by default. By the absence of an early detection protocol that has never been established because the financial incentive to establish it does not exist in the current model. The test that comes closest is CA19-9, a tumor marker that, in combination with symptoms, is a strong indication for abdominal CT or MRI. Ask your doctor specifically for CA19-9 if 3 or more of the 7 signs apply to you, not as a diagnosis, as a reason to look further. Pancreatic disease affects an estimated 3 million Americans with chronic pancreatitis and accounts for approximately 64,000 new cancer diagnoses per year. The peak incidence is between 55 and 70 years of age. After 50, the risk rises significantly, and the window for effective intervention narrows with every year that symptoms go uninvestigated. The 7 signs I described today are not rare. They are sitting in the daily experience of people watching this right now, being explained away as irritable bowel, perimenopause, a bad back, or stress. They are not those things. They deserve investigation. How old are you? Write it in the comments right now. I want to know who is watching, because the pancreatic risk conversation at 52 is different from the conversation at 68. And what I cover next will be shaped by exactly where you are. Review the 7 signs: floating, pale, greasy stools, upper abdominal pain radiating to the back, unexplained weight loss, new onset diabetes without risk factors, bloating within an hour of eating, yellowing of skin or eyes, mid-back pain that does not respond to any treatment. 2 or more, request a lipase blood test and abdominal ultrasound. 3 or more, request CA19-9 and abdominal CT. Do not wait for your annual physical. Request an appointment this month. Your pancreas has been working silently for your entire life, filtering, producing, regulating, without a single complaint. It deserves 5 minutes of your attention today. I'm Dr. Arthur Sterling. I have spent 15 years watching patients arrive after the window for effective treatment had already closed, wishing someone had read the signals earlier. Subscribe, hit like, and send this to someone you care about. The healthcare system profits from treating advanced disease. I profit from making sure you never get there.